call, and this patient struggles with an instability at the upper cervical spine. So where that first vertebrae meets the bottom of the skull. And an instability at the occipital atlanteal joint, or even the atlantoaxial joint, C1, C2, can be very, very threatening and dangerous and harmful to the spinal cord just underneath there. So it's a very, very, very critical area and needs to be supported and addressed. This patient struggles with neurological symptoms, balance issues, and has received treatment for stability. So there are really phenomenal regenerative medicine doctors out there doing brilliant, brilliant work in helping build stability through the ligamentous system. So helping those ligaments that hold those vertebrae together be a bit more solid, a bit more stable, which has been helpful. What that hasn't addressed still is the underlying, what has driven or drove that instability in the area. And there are some other factors involved that I'm not going to go into. What I want to speak to, though, is how, as regenerative medicine comes in and creates stability, which is what the system needs, we need to come in as physical therapists and provide additional muscular stability to that region as well. The unfortunate piece is a lot of general PT, a couple things. So this woman has gone through several rounds of PT, and often she feels worse afterwards. A lot of the conventional PT, it's stretching, which we already have a hypermobility area, which doesn't mean that there's hypomobilities or areas of tightness elsewhere. But also, the approaches to stability still tend to be from a global perspective. For example, I said, give me an example of what you were doing in physical therapy and how did you respond to afterwards. So the exercise that was given to her for her upper cervical stability was planks, which I personally don't even do planks very much at all, because planks are asking outer stabilizers to do. Most of us don't have the deeper underlying stability and or alignment to have the true core fire to stabilize the spine, and it's such a long axis, so it really does. If you're planking from your toes on elbows, it puts a lot of strain on that low back and neck if you don't have the inherent alignment, mobility, stability to protect that spine. And then mostly it's really helping outer muscles work, which we need the inners to work. As she did this exercise, which was the next piece in stability for her, it created more neurological symptoms immediately afterwards. And then a few hours later, she, I believe, was struggling with balance or so. But it was interesting, and it was important to really notice how the system responds to a particular exercise or a particular treatment immediately afterwards, a few hours later, and then the next day. So these planks really were derailing her. The conversation was about how can my clinic help support this deeper need for stability. And it's not a simple conversation. And even if we went in there and said, hey, little unisegmental muscles, very precisely, can we get you to fire? The question is, it's really not even so much a matter of strengthening, it's a matter of, can we get them to turn back on? They've been inhibited, likely. And then how do we get them, how do we teach them how to turn on and then get them stable? But not just in that area. We have to have stability throughout the whole system. Which brings me to the bigger piece of it, all of it, and the bigger conversation I had with this family. I said, what's important to know, yes, we will absolutely explore what do we need to do to safely and effectively help these couple segments become more stable through a neuromuscular facilitation response exercise program, which again, it's going to be a lot of hands-on, lots of really precise cueing and helping this person figure out how to fire where, bringing in base of support. Again, it's not going to be here, do this exercise, because we need precision when we're dealing with an instability anywhere, especially when we're dealing with an upper cervical instability. What's equally, if not more important to consider is how do we get there in the first place? So there is history of Eagle syndrome, so excessively big styloid processes, which absolutely can affect vascularity to the brain. Carotid artery, jugular vein, there's also more history there that I don't know yet. But what I shared with the family is how we also need to look at the entire system from head to toe. We need to bring into consideration the dural system, which nobody has spoken to or asked questions of yet. How well is the excursion of the dural system, the brain and the spinal cord? And if there is tension somewhere on that dural system, that can also create tension somewhere else. So my curiosities lie into, is there anything else in the body, perhaps in another system, whether it's the dural system or the fascial system around the vascularity, or maybe an organ or somewhere else? Is there something else in the system that continues to precipitate or mediate the instability up at the cervical spine? And then on top of that, also driving the difficulty of those unisegmental muscles to fire at the right place at the right time. So I brought to the conversation this bigger piece of, is there anything else around as we look at the whole organism, the whole person from head to toe, that might be contributing to these challenges up here at that very specific area. Also very important for us to go back into history to see what else has happened to the system, because there's no incidents of mechanical trauma. There was not a manipulation that happened that created instability, no car accident that we're aware of that created this instability. There is underlying hypermobility syndrome, Ehlers-Danlos, some of the connective tissue pieces. But even with those conditions, and they're often genetic in nature, and yes, there's hypermobility in not only the fascias, but often in ligaments, in vascular walls. It affects multiple tissues. Often in these patients, there are lurking in the system deeper areas that are stuck, that have lost mobility, which puts more demand. When we have an area that doesn't move well, it puts demand somewhere else on the body, and then you throw hypermobility on top of that. So I'm very, very curious to see, once I put my hands on this woman, what we're going to see and feel and notice with regard to the concept of tug of war throughout her body. Is there anything else we can address and optimize with our hands? Can we help unburden her system so that we can further support the stability of that upper cervical spine? Looking at the big picture, asking the next right question, thinking about an area within the big picture of history of trauma and compensations and tug of war.